Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Louis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. As always in our sessions, only the speakers will have audio. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in the meeting control toolbar. To toggle the meeting control toolbar permanently on, press your Alt key. One moment. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656 and use the webinar ID of 864-8854, 2838. And note that this is not a toll-free number. Also, I want to remind everyone that the webinar is being recorded and will be available in the adapresentations.org archive in the healthcare section next week. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. Upcoming sessions are available at adapresentations.org under the Schedule tab in the Healthcare section. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific time. By being here, you are on the list to receive notices for future webinars in this series. Those notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the healthcare schedule page at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session. So feel free to submit them as they come to your mind. You may type and submit your questions in the chat box, or you can press Alt-H and enter to use the chat area if you are using keyboard only. If you are listening by phone and not logged into the webinar, you may ask questions by emailing them to ADA-Tech, that's ADA-TECH, at adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to the host by typing in the chat window, type your comment in the text box and enter. Or if you're using keyboard, use Alt-H to access the chat box and type in your message. You can also email us the message at adatech@adapacific.org, or you can call us at 510-285-5600. Today's ADA National Network Learning Session is titled Accessible Medical Care and Long-Term Care Facilities. This session will provide an overview of the minimum requirements in the ADA and Architectural Barriers Act, or ABA, accessibility standards for medical care and long-term care facilities. The presenters will review the scoping and technical requirements for accessible routes, parking at specialized facilities, patient rooms for both medical and long-term care facilities, alarm systems, and toilet rooms in intensive care units. Finally, the presenters will provide a brief overview on the requirements for medical diagnostic equipment. Today's speakers are Bill Botten. Bill Botten serves as the Training and Technical Assistance Coordinator at the U.S. Access Board. And Bobby Stinnett. Bobby is an accessibility specialist at the U.S. Access Board with a focus on medical diagnostic equipment and healthcare. I will now turn it over to both of you, Bill and Bobby.
Great, thank you, Louis. I'd like to also thank you for the invitation and the opportunity to speak today at this webinar. The issues that we're going to talk about, as Louis talked about, are going to be the medical care facilities and long-term care facilities, and how important it is to make sure that we make them as independent and usable by people with disabilities as possible. Today's agenda is going to cover the facilities that the application applies to, patient sleeping rooms, parking, passenger loading zones. We'll talk about the accessible route requirements, either within the site or within the facility, to include employee work areas, service counters, public and common use areas, and as Louis said, finally we'll end up with a brief overview of the medical diagnostic equipment voluntary standards issued by the Access Board. If we could move on to slide number 8. Slide number 8 is our title slide, and it's introducing the chapters and sections of where you can find the scoping and technical requirements, and I'm going to turn it over to Bobby from here.
All right, so thanks, Bill. So in today's webinar, I'm going to go over the basics and some of the common questions, and then some of the areas of confusion also related to medical care and long-term care facilities. And you'll find those referenced in section 223 and then 805 of the ADA standards. Okay, let's move on to the next slide, slide number 9. All right. So what are we talking about when we look at medical care and long-term care facilities? Now, the type of medical facilities called out in the standards are hospitals, rehabilitation facilities, like psychiatric facilities, and detoxification facilities, and long-term care facilities are specifically addressed. Now, an example of that would be a skilled nursing facility that provides care to its residents, including assistance with activities of daily living. All right, so let's move on to the next slide, slide number 10. Now, we're also referring to medical units and detention and correctional facilities. I'm not going to really discuss that during this webinar, but we'll talk about in terms of professional offices of healthcare providers, such as those of a general family doctor or a dentist. And these, for the most part, they're not specifically addressed in the standards, except for the vertical access requirement. Now, to be clear, those spaces would need to comply with all the other requirements. And then many of the typical issues like reception counter, single user toilet rooms, dressing rooms that regularly come up, the requirement for these are no different than it would be for other types of facilities. Okay, so let's move on to the next slide, slide number 11. And let's talk a little bit about patient sleeping rooms. And so we do receive many questions about when looking at licensed medical care facilities or licensed long-term care facilities and then medical facilities where the period of stay exceeds 24 hours. So if that's the case, then more than likely you're going to have sleeping rooms, right? Now, this is one area where there are some important differences. So let's go to the next slide, slide number 12, and talk about those differences. Okay, so patient sleeping rooms provided in hospitals, rehabilitation facilities, psychiatric facilities, and detoxification facilities are covered by the standards in section 223.2. Now, whether or not the facility specializes in treating conditions affecting mobility is going to be critical in determining the percentage that must provide features for mobility access. So for hospitals, rehabilitation facilities, psychiatric facilities, and detoxification facilities, where they specialize in conditions affecting mobility, then the rooms are required, so 100% of the rooms are required to have mobility features. Now, when they do not specialize in treatment affecting mobility, then only 10% are required to have mobility features. And now, additionally, for licensed long-term care facilities, as is referenced in section 223.3, it requires that 50% of patient sleeping rooms provide mobility features. Okay, so let's move on to the next slide, slide number 13, and talk a little bit about patient sleeping rooms and dispersion. Now, in the 2004 ADA accessibility guidelines that the board issued, there was an advisory about dispersion in reference to patient sleeping rooms. But when the 2010 ADA standards were issued by the US Department of Justice, sections were included in the final document requiring that accessible patient rooms be dispersed in a manner that is proportionate by the type of medical specialty in the facility. Now, this applies to those facilities that do not specialize in treatment of conditions affecting mobility, because those that do, it will be required to be 100%. So there's no dispersion issue. Okay, so let's move on to the next slide, slide number 14, and talk a little bit about patient sleeping rooms and alterations and additions. And so when sleeping rooms are altered or added, the requirement of section 223 only apply to the rooms that you are altering or adding. So for example, if I had a facility that is not specializing in treatment affecting mobility, and remember, as I discussed earlier, that 10% of patient sleeping rooms are required to have most mobility features. And so let's say, for example, that I had 100 sleeping rooms and then I altered 2 of the rooms, then I would be required to provide 1 accessible room. That is 10% of 10 and not 10% of 100. Okay, so that's how that relates to when we talk about patient sleeping rooms and then alterations. All right, so let's move on to the next slide, slide number 15, and talk a little bit about long-term care facilities. So when we talk about long-term care facilities, because we do get this question on this topic where people are not clear if this requirement applies to their facility. Now, it's important to keep in mind that this requirement is not concurrent with the International Building Code occupancy classifications. Now, those classifications really are likely to be important when determining the type of facility under, let's say, a state code. So as most states have adopted the IBC, the International Building Code, so there are different requirements. And I always tell people, if you're unsure if your facility would fall under the long-term care category, you can contact your state board, or you can contact the Department of Justice for that to make sure to see if your facility would fall under that or not. Okay, so let's move on to the next slide, slide number 16, and talk a little bit about doors. Okay, so let's talk a little bit about lat side clearance as it relates to doors. So there is a minimum requirement of 18 inches of clear floor space on the pool side of doors. But what people sometimes forget is that this needs to always remain clear. Many times staff or other people, they will see this space and they think it's a great place to put like a chair or a cart or some type of piece of equipment. However, this space has to remain clear as you never know who needs to be utilizing that space. So it's important to remain clear of that space. Now, on the image on the right, what we show is one hospital. What they did is they put a sticker on all of their carts to remind people not to leave the cart in that clear space. Okay, so let's move on to the next slide, slide number 17. Now, you also have to pay attention in what direction someone is traveling as they approach the door. So for example, if you're coming straight at the door, perpendicular to it, the clear space at the latch side needs to be at least 18 inches. But if you're approaching the door parallel to it, as we show on the diagram here on the slide, you need to provide 24 inches of clearance. Now, also hospitals and nursing homes, they're required to have doors to the sleeping rooms, providing a minimum of 41.5 inches of clear opening. Now, the ADA allows for these larger doors in hospitals only to be exempt from the poolside clearance space. Now, to be clear, this exemption is for hospitals only, and nursing homes still have to provide that 18-inch poolside in addition to the larger one. Okay, so let's move on to the next slide, slide number 18. Okay, so let's talk a little bit about turning space in all rooms and spaces as it relates to licensed long-term care facilities and then medical facilities. So you can either do a 60-inch diameter turning circle, or you could do a T-shaped space. Now, to keep in mind, that 60-inch circle, that's really just the minimum piece that you can do. Sometimes, especially when you have, like, you're in a nursing home or if you're in a facility, you may need to add additional space. So for ease of maneuverability for the patient. Okay, so let's move on to the next slide and look at slide number 19. Okay, so on this slide, we show a good example of a sleeping room design that shows access to both sides of the bed. And then there's plenty of room at the foot of the bed for turning space. Now, keep in mind that both hospitals and nursing homes, there are often lifts and other pieces of equipment that are used that can take up a lot of space. And they also need room to maneuver and to maneuver around, right? So designing the sleeping rooms to meet the minimum standards is good, but the more flexibility as it relates to maneuverability, the better. Okay, so let's move on to the next slide, slide number 20. And talk a little bit about patient sleeping rooms and then toilet and bathing. So now, of course, it should go without saying that toilet and bathing rooms that serve fully accessible sleeping rooms often need to be fully accessible, right? And again, keep in mind that a little bit of extra maneuvering room can really go a long way. And then now I also want to make note that there is an exception in those instances where the toilet room in like a critical care or an intensive care patient room, they don't have to be accessible. And I think one of the reasons behind that is that when you're a patient and you're in like intensive care or critical care, you're not typically independently trying to go into the laboratory or the toilet room by yourself. Okay, so let's move on to the next slide, slide number 21. Okay, so this slide In this slide, it shows that in new construction, that all toilet and bathing rooms must be accessible for both public and common use. Now, there are two exceptions in this rule. So one is, let's say that you have portable toilet units that are clustered, then only 5% of each type are required to be accessible. And then also, if you have a single user toilet room that are clustered, then you're required to have a minimum of 50% of each type be accessible as well. And you can find the scoping for toilet and bathing too on section 213 of the standards. Okay, so let's move on to slide number 22. So I want to make note of an ongoing working group that's going on right now with the American National Standards Institute, or ANSI, the A117. So the ANSI A117 on assisted toilet and bathing facilities. Now, the goal of this working group is to really establish technical requirements on toilet and bathing facilities designed for assisted use. And I think a part of this is really about seeing about maneuverability, making sure it's like, so for example, when you have like assisted living, nursing homes and rehabilitation facilities, resident bathrooms, because this is more about assistant use as opposed to independent use. And so the goal of the working group is to be able to provide like some technical guidelines behind assisted use, and with the goal of being able to add it to the IBC, the 2021 version of the IBC. Bill, did you want to add a little bit to that as well?
Yeah, thanks, Bobby. One of the issues, when we're looking at assisted toilet and bathing is that additional space maybe on the inside wall or next to the water closet or toilet. In the graphic that we're showing you, we're also showing some fold down grab bars that may assist to have, on the open side, an additional grab bar for somebody, or the additional space all around that toilet so that people could help from both sides. And so what they're looking at through this committee is what should some of the minimum requirements be in some of these unique facilities that are really providing assisted living and need additional space, unlike when we're trying to provide an independent toilet room facility for anyone, whatever type of facility. So um, I think it's really important, and we're going to talk a little bit later about how important it is to make sure that the toilet or bathing facility really meets the needs and encourages the greatest level of access that you possibly can, and whether that's for children or for elderly, and especially when you're in your own, you're in your own house.
Mhm.
Um, that's really the best way of all, right? Is where you can set it up so that you can be as independent as possible. And this can be a very dangerous place, right? The toilet room or bathing room is really one of those dangerous places where things are wet, and maybe you've just taken a shower or you're not feeling so well and you're in there and falls occur. So
Exactly.
we want to make sure that these are very safe and usable and as independent as possible.
Good.
Okay, so
Thanks,
I
Bill.
think, yep, we're going to move on to slide. I believe the next one is 23. And it says communication features. If we could just move again to slide number 24. Um, I wanted to highlight that if your facility is still providing either a coin operated or a public pay telephone, a coinless public pay telephone, or some type of public closed circuit telephone or public courtesy phone, that you understand that there's still a requirement for a TTY, a text telephone. Um, and the graphic that you see is one where you see an individual standing at a counter and actually typing the message to another TTY or through the relay to use a public payphone. And so the requirement is that within uh, wherever these public payphones are provided, that at least one, if there's even one, public payphone is provided serving a hospital emergency room or a hospital recovery room, or maybe it's in the waiting room, that at least one public TTY be provided at each location that you provide a public payphone, okay, to deliver that communication access. If we could move on to slide number 25. Slide number 25 is fire alarm systems, and it gives you the provision numbers for the technical requirements, which is brings you to a reference standard. And we reference the National Fire Protection Agency, I'm sorry, Association, and we've given their website on this slide. We referenced the 1999 and 2000 versions. So fire alarm systems permanently installed with audible and visual alarms have to comply with those two versions. And it's incorporated by reference. So you won't find it in the 2010 standards. You're going to have to find it in the reference standards. And we give all the information for those reference standards in in the in chapter 1
Mhm.
of the 2010 standards. And so you can find the notification information besides the website right here, where you can get a copy of NFPA Senate 72. They do provide an exception. If we can move on to the next slide, slide 26. Slide 26 highlights that exception, and that is if you have an industry practice that maybe controls the use of that fire alarm system, maybe it's an assisted care facility where you don't want everybody trying to get up as fast as they can and run to the door, that you have staff there to notify and help evacuate people. And that's how the industry handles an emergency. It's not through a notification in each room, but it's through notification by staff. There is an exception here that fire alarm systems in medical care facilities are permitted to comply with that local industry practice or state practice. Moving on to slide number 27, and slide 27 is just a title slide again for switching topics to parking and passenger loading zones. If we could move on to slide number 28. Slide number 28 is talking about new construction and where access is required. Remember, you don't have to provide parking, but if you do provide parking, you have to provide accessible parking. There is an exception that excludes, commercial vehicle storage or law enforcement vehicles or vehicle impound. But typically in a medical care or long-term or facility, we're not typically talking about vehicle storage or law enforcement vehicles or vehicle impound parking. Okay, we're going to move on to slide number, the next slide, please, 20. Okay, so accessible parking, the scoping requirements are based on where you provide visitor, patron, or employee parking. Okay, it's all the above. It's calculated on a facility by facility basis. And a facility could be just a single space to a parking lot, a parking structure, or just a standalone parking building or structure. So the scoping requirement is based on facility by facility, based on if it's one space or a parking lot. And then we're going to move on now to slide number 30, and that'll show us the scoping requirements that you find in the table at 208.2. You find it for both federal facilities and state and local government or private hospitals, all covered by Title III, would all have the same requirements. So you see here, based on the number you provide, and a lot of times this can be done just by looking at Google Maps. You can hover over a facility and look at the map and determine how many parking spaces serve that facility. Remember, you want to make sure you got the ones that serve each specific entrance, but you come back to this table, and based on the number of parking spaces provided, you determine how many spaces need to be accessible. So if we can move on to the next slide, it's slide 31. Slide 31 moves into some more of the scoping. And one thing that's can be a make or break for a lot of people is whether or not you can find parking close by or parking that meets the need. If you're a person that's using a vehicle that has a lift or a ramp that comes out of the passenger side, so that you need additional space with a van accessible parking space. So parking is such an important feature for site arrival. And Bobby's going to go into a little bit further about accessible routes and site arrival, but for the site arrival for parking, there's an increased scoping from the table that I just showed you in the last slide. And so if it's a hospital outpatient facility, and we give an advisory about the term outpatient, it's not defined in the standards, okay, or the document, but it's intended to cover facilities or units that are located in hospitals that provide regular and continuing medical treatment without an overnight stay. Doctors' offices, independent clinics, and other facilities not located in hospitals are not considered hospital outpatient facilities for the purpose of the 2010 ADA standards or the Architectural Barriers Act. So the requirement for hospital outpatient is 10% of the spaces need to provide access. If we're talking about a rehab or an outpatient physical therapy facility, 20% of the patient and visitor parking spaces served to serve that rehabilitation facility, specializing in the treatment of conditions that affect mobility, and outpatient physical therapy facilities, we're looking at a minimum scoping of 20% of the overall number need to comply with Section 502 and be accessible parking. So we also provide another advisory about what is physical therapy or conditions that affect mobility. And the advisory states that requiring the use of an assistance brace or a crutch, maybe a cane, a prosthetic device, a wheelchair, whether it's powered or manual. Um, if you have an arthritic or neurological, or maybe an orthopedic condition that could severely limit your ability to walk, it could maybe be a respiratory or another condition, which may require the use of maybe portable oxygen, or cardiac conditions that impose, a significant limitation on your ability to go distance. Um, it's always easy to judge people when you see them getting out of an accessible space that they don't really need it. But just like I was just sharing with you there, don't prejudge what somebody's issue is and why they would need that accessible parking space. It's so important to understand that there's so many conditions that may not be visible that still need that accommodation of an accessible space. And when we're treating people with that mobility that affects a mobility issue, I mean, the parking spaces need to be close. I'm a person that uses a manual wheelchair, and I I'm older now, and so I like a van that's got a ramp in it to make it so much easier. And I'm looking for the van space, the space that requires the larger access aisle to get the lift or ramp down so that you can then exit the vehicle from the wheelchair or power device. And um, I actually think that it would be better to design these facilities to where the van spaces are further away from the facility entrance and provide more of those spaces that are, say, the car space or the one that only requires the 5-foot access aisle to be closer to the door. Because so oftentimes people that are using the mobility device, it's not necessarily the distance we need to travel. It's more so that we need the extra space. And when they're the closest to the entrance, what happens is they're taken first by persons that use the vehicle or car that don't need the extra space for the ramp or lift. So I think it makes it easier to find the van space if they're not the closest one. Okay, we're going to move on to slide 32. Slide 32 just is getting you back to the chart in 208.2. And the chart gets you back to 208.2 because you don't have an additional scoping just for a doctor's office or for a medical equipment rental facility. You still just come back to the one table that would be the same for a restaurant or a hotel or whatever else. Okay, so there's not an additional scoping for a doctor's office specifically. We're going to move on to the next slide, slide 36. Slide 36 is a graphic of kind of an overhead view of a site, and it incorporates a building and then a couple of parking lots and then also a satellite lot. And we often get questions about the location of where those accessible parking spaces need to be. And so Parking spaces that are the accessible ones that serve a specific or particular building or facility are required to be located on the shortest accessible route from parking to the entrance that they serve. Okay, so where parking serves more than one accessible entrance, parking spaces that are accessible need to be dispersed and located on the shortest accessible route to all the accessible entrances. And if parking facilities that don't serve a particular building or facility, the parking spaces that are accessible should be located on the shortest accessible route to the accessible pedestrian entrance to that parking facility. Okay. Now, parking spaces are permitted to be located in different parking facilities as long as and if substantially equivalent or greater accessibility is provided in terms of the distance from the accessible entrance or entrances, the parking fee, or user convenience. And so what we're saying there is that you really need to keep the accessible spaces, as you see in this graphic, highlighted to the accessible entrances, but dispersed to each one of them. And that satellite lot you would count individually and put the additional spaces that were required in that satellite lot closer to the building so that you could facilitate being on the shortest accessible route. Moving on to slide number 37. I'm sorry, 34. Slide number 34 brings us into the passenger loading zones, and it gets you straight to the technical requirements, because here's what we wanted to highlight: that at a passenger loading zone, it's on the passenger side of a vehicle. It's a 60-inch minimum width, doesn't have to be demarcated or identified, um, but it needs to be at the same level as the parking space. And if there is a curb, you would have to have curb cuts that are cut into the curb itself and not built up into this space. The idea here is that most oftentimes the person with a disability is going to be getting out on the passenger side, and you don't want to change in level like a curb, a bollard, or anything in this way, so that ramps or lifts or mobility devices could be brought out from the passenger side of the vehicle. Okay? If we can move on to the next slide, slide 38. I'm sorry, slide 35. Slide 35 is the scoping requirement for the passenger loading zone, and it says required where a period of stay exceeds 24 hours. No canopy is required per the 91 standard. That was the earlier provision. But a passenger loading zone would be required, at least one, um, provided at the accessible entrance to a licensed medical care and a licensed long-term care facility where the period of stay exceeds 24 hours. There's also a requirement in 209.4 that requires parking facilities that provide valet parking services. It seems like when I go to the doctor anymore, there's somebody there that will park your car because it's so hard to find one, right? So if you have parking, valet parking services, you have to provide a passenger loading zone. So there's an opportunity for a person with disability to get out, but then the valet could take the vehicle. Now, a lot of times adaptive equipment vehicles cannot often be driven by persons that don't understand the technology or have a license to drive that certain type of technology. And so it's going to be important that there be an alternative way besides only valet that vehicles with these accessible features have, that they can still park their own vehicles. Okay, moving on to the next slide, slide 36. Slide 36 says, here's that canopy. If you do decide to provide it, okay, it has to be a minimum of 114 inches. That will allow a raised roof vehicle, such as a raised roof van, to be able to get underneath that canopy. Okay, 114 if you decide to put up the canopy. Moving on to the next slide, slide number 37. It talks about the signage. You know, it's so difficult to understand where these parking spaces are if they're not signed. The standard doesn't require the international symbol on the ground. It only requires a sign and the access aisle to be identified or marked. So the international symbol is the one to use. If you're thinking about using the speedy wheelie or another type of international symbol of accessibility, um, we have a good guidance document about that. It's really making sure that people can still understand that it is the ISA or international symbol, then you would have to claim equivalency because the standard specifies this actual pictogram be used. The sign must be 60 inches minimum to the bottom edge of the sign. Van accessible must be added to those spaces that are required to be van accessible. That is 1 of every 6. So if you had 1 space, it'll be van accessible. If you had 7 spaces, you'd have 2 van accessible. There's an exception that you don't have to even have a sign if there is 4 or fewer spaces in the whole parking lot, okay, including the accessible one. Moving on to the next slide, slide number 38. I wanted to remind people that, remember, an accessible route is required to any of those parking meters or pay stations. At least one of each type would be required to be accessible, which would mean we're looking at the reach ranges as you see identified here in this yellow squared off area, a minimum of 15 from the floor, a maximum of 48. All operating mechanisms would need to be within that square. We'd also have to have a clear floor space for a parallel or forward approach to the machine. Oftentimes I find they're up on a curb. They're in a location that may not be wheelchair accessible. So make sure that they are on an accessible route. You do have the clear floor space and operating mechanisms. I find it also, if there's some way that you can call for help if you are having trouble with the machine, is always very helpful. Next slide, please. The next slide talks about, and I believe this slide 39, talks about electric vehicle charging stations. I think maybe we neglected to say at the very beginning of this webinar that we're talking about the federal requirements under the Americans with Disabilities Act 2010 ADA standards and the Architectural Barriers Act accessibility standards, but that your local or state building codes, as we alluded to earlier on the discussion with the IBC, may incorporate greater requirements or already requirements for these electric vehicle charging stations. I just wanted to remind people that the standards don't specify specific provisions for them. Here you see me in this photograph actually reaching where the charging device and cord and dispenser is actually up on a curb and beyond reach. It's advisable to address the access to EV charging stations so they'll be usable by people with disabilities. So in this case, it should have been all at the same level with the clear space adjacent to it. And if you do provide them, the spaces for charging electric vehicles cannot be counted towards the minimum number required for accessible parking and van parking for the facility. Okay, we're going to move on to the next slide. And I'm going to turn it back over to Bobby, accessible routes.
All right, so thanks, Bill. So now we're going to talk a little bit about accessible routes, the requirements overall, and then we're going to talk about as it relates to medical care and long-term care facilities. Okay, so let's move on to the next slide. I think that's slide 41. So now in this slide, what we show the requirements for site arrival points. Now, site arrival points include accessible parking spaces, and then passenger loading zones, public transit stops located within sites, and then public streets and sidewalks along the boundaries. Now, this can sometimes be a challenging issue, especially depending on like the landscape or the terrain. And then also sometimes other entities can control portions of the route. So what we're showing here on the slide is that at least one accessible route to building entrances from site arrival points must be provided, okay? And then you can find the scoping for accessible route requirements in section 206, as we stay here on the slide. All right, so let's move on to the next slide, slide number 42. So also in the slide, what we show is where accessible routes are required. And then we say at least one accessible route, it must connect to each accessible room and space. And then also one has to be for each story. Now, unless there's like an exception for vertical access, then it wouldn't be required. But also we talk about for accessible for each accessible element, as we show here on the slide, where we show access to the drinking fountain that you have, that's an accessible element. And then lastly, you have to have at least one accessible route that must connect to each level on a floor required to be accessible as well. Okay, so let's move on to the next slide, slide number 43, and talk a little bit about handrails along routes. Okay, so also, let's talk a little bit about the handrail piece. So for handrails were provided along walking surfaces, other than ramps or stairs, also, they must also comply. Now, there is an exception, but it's not really for this area, but if there was like an assembly area, there's an exception for handrails. But in this situation, if the handrails are provided along walking surfaces, like I said, other than ramps and stairs, they must comply with the standards. And you'll find that in section 403.6, the technical standards. Okay, so let's move on to the next slide, slide number 44. Now, what's important to note is that the accessible route must coincide or be in the same area as the general circulation path. And then also, if the circulation path is interior, then the accessible route needs to be interior as well. And this is really important. You don't want to have inside where you have an interior route, and then someone with a disability, you have that in a whole nother area. You know, you want to have them in the same, if it's interior, the circulation path is interior, then the accessible route needs to be interior. And then also the routes, including exterior routes, must coincide with or be in the same vicinity as the general circulation path as well.
Hey, Bobby, I'll jump in real quickly here. This is new to the 2010 standards. Remember, in the earlier standard, and you may have some older facilities that didn't have this requirement that the accessible route coincide or be interior if that common circulation path is interior. And so it's so important as an integration issue to be able to incorporate that circulation path and accessible route as close to as possible the same. So that the person that's using a mobility device doesn't have to go out and around or doesn't have to go on some wild goose chase to get to the same place that everybody else can just walk over to.
Exactly. That's a great point.
Yep.
Okay, so let's move on to the next slide, slide number 45, and talk about vertical access. So now in guidance from the Department of Justice, where a professional office of healthcare providers is, where the state regulated professional provides physical or mental health services to the public. So if you have a 2-story building and you design it to house the professional offices of, let's say, a healthcare provider, it will require an accessible route between levels. And then for all practical purposes, you would need an elevator. Now, however, it is possible that if you have a physician's office where only all of the physician offices were only on the first floor, then you would not be required to provide an accessible route, let's say to the second floor of the building, or a building with less than 3,000 square feet per floor. Now remember, if you do that, that means that the building can only provide healthcare offices on the first floor, unless you are willing to have an elevator. Now again, Title II facilities, state and local governments would not get this elevator exception to begin with. And then also the Architectural Barriers Act, ABA, which covers federal facilities, you would also not get this exception for vertical access as well. Okay, so let's move on to the next slide, slide number 46. And talk a little bit about multi-story facilities. So in multi-story buildings and facilities, as noted here on the slide, at least one accessible route shall connect each story and mezzanine. So in a multi-story building, right? Now, unless there is an exception, like an example would be like in a private buildings or facilities that are less than 3 stories, or it has less than 3,000 square feet per story. So if that is the case, then an accessible route is not required to connect stories. And I'll talk a little bit about this exception more in the next few slides. And you can find that in section 206.2.3 Okay, so let's move on to the next slide, slide number 47. So for Title III facilities, those are public accommodations and commercial facilities. We have what is called, of course, an elevator exception, which is in section 206.2.3. Now, the exception is in multi-story buildings. So if the building is less than 3 stories, or if there is less than 3,000 square feet per story, which means that it's either a 2-story building or kind of a narrow, taller building, then you don't have to meet the requirement to provide an accessible route between the levels of the building. Now, you have to meet all the other requirements, but you don't have to have the accessible route, which is typically means that you do not have to have an elevator. Thus, that's the elevator exception. However, professional offices of healthcare providers, they don't get this exception at all. Okay, so let's move on to the next slide, slide number 48. Okay, so now let's talk about the exceptions if you have a building that would otherwise qualify for the exception, but has, let's say, an excluded occupancy, like a healthcare provider or a shopping center or sales and rental establishment. You must provide vertical access to those occupancies. So if you have a 2-story building with a healthcare provider on the 2nd floor, and you have sales and rental establishments of 5 or more scattered to different stories, you will need vertical access in order to serve those particular occupancies. Okay. All right, so let's move on to the next slide, slide number 49, and talk about protruding objects. Now, when looking at protruding objects, so any objects mounted on walls or partitions, columns, and then other elements along a circulation path, it can really pose hazards unless the projections are limited, right? Thus, when a cane is used and the elements is in the detectable range, it gives a person sufficient time to detect the element with the cane before there is body contact. Now, anything along that circulation path, like a water fountain, a wall sconce, could create a hazard for someone that is visually impaired. So now, objects with leading edges more than 27 inches and not more than 80 inches above the finished floor or can only protrude 4 inches maximum horizontally into the circulation path. Okay, so let's move on to the next slide, slide number 50, and talk about signs. And Bill, I'm gonna turn that over to you.
Yeah, I'm glad to be back. I've been coming in and out a little bit here. So if by chance I lose it again, I'll be calling in. Tactile signs and visual signs and signs that are exempt is the slide we're currently on here, slide number 50.
Okay, this is Lewis, and we seem to have lost Bill again. So he will call back in. So,
Yep.
Bobby, do you want to move ahead to the other slides that you were going to take, or how would you like to proceed?
We can go ahead and I'll start, and then Bill will come in and finish up with this.
Okay.
Okay. So there's requirements in the sign section, in section 216. Before we do that, essentially, I want to give kind of a brief overview of the requirements, which you'll find. There we go. You got it, man? Uh-oh. Did we lose you again?
Hello?
Hi, Bill. We can hear you now.
I am so sorry. And if I have this again, I will call in directly. But tactile signs are those signs that are at or identifying permanent rooms or spaces and exit doors. Visual signs are going to be those that are directional and informational. And signs that are exempt are those that are temporary, a building menu, a directory, an address, or a company name or a logo. Moving on to the next slide. The next slide further talks about those signs required to be tactile, and they are interior and exterior. But I think the real thing to remember is that they're either located at a restroom, or they're a room number, they're at a floor level, or they're an exit discharge, or an area of rescue assistance. That's where typically you're going to find a tactile or raised sign. Remember, the idea here is that a person that is looking for a tactile sign is going to have the ability to go along the wall or go along the edge of the wall to find the door and to actually find then the tactile sign. Moving on to the next slide. So these are required signs at a means of egress, at parking, we just went over parking, at entrances, if not all are accessible, at elevators, toilet and bathing rooms that are not all accessible. There's a specific pictogram for TTYs, assistive listening, and if not all checkout aisles are accessible, those that are require the international symbol. Moving on to the next slide. Bobby, back to you.
All right, thanks, Bill. Okay, so I'm going to take a little time to talk about employee work areas. And we do receive questions about employee work areas as it relates to medical care and then long-term care facilities. Okay, so let's move on to the next slide, slide number 54. Now, just to review what an employee work area is, and this is in the definition section of the standard, section 106.5. So it's any or all portions of a space used only by employees and used only for work. Then it goes on to say that corridors, toilet rooms, kitchenettes, and break rooms are not employee work areas because in essence, they really serve as supporting employees, but not for the purpose of work. Now, under the Americans with Disability Act, employee work areas, limited access is required at least to the point where you're able to approach, enter, and exit the space. Now, as far as the Architectural Barriers Act, employee workspace has to be accessible just like any other public or common use space. So there are distinct differences between the ADA requirement as it relates to employee work areas versus the ABA requirements. Okay, so let's move on to the next slide, slide number 55. So when we talk about employee work areas, let's look at employee work areas and a sink as for an example. So in healthcare environments, here is an image that we show as part of an exam room with a sink in the corner and an exam table. So some medical care spaces are actually a combination of both public spaces and employee work areas. And a good example in the image is we show here on the slide is a hand wash sink in the work counter, right? Now, the work counter would likely be an employee workstation. So those would not be required to be accessible. So just because they are in a public space, it does not mean that they have to be accessible if they truly are work area used only by employees. Because remember, our only obligation for employee work areas is approach, enter, and exit if you're using the ADA. Now, the sink here that we show on the slide is an example, but it depends. So if the sink provided is for staff, then it's a workstation and only staff is using it. It is not required to be accessible, even though it is in a public and common use area space. But if that sink is necessary for patients to clean up, let's say after a procedure, then it would need to be accessible. So you do need to evaluate who is using what to determine the accessibility requirements. And then lastly on this, just because it is possible for a patient to use the sink, that's not the criteria of how you evaluate it. It's the sink. What's the intentions for the sink? It is the sink intended to be used by the patient. So you have to look at how you evaluate it. Okay, so let's move on to the next slide, slide number 56. Okay, we're going to move on to the next area and talk a little bit about service counters. This is another important area. I'm going to hand it over to Bill. Bill?
Okay, how about we move on to the next slide? There we go, slide number 57. And slide number 57, we thought it was important to talk a little bit about sales and service counters, more so service counters. We're figuring, after you've parked, you've come in, you know your accessible route requirements. What's the next requirement you're going to hit? You're going to hit somebody at some type of a service counter, right? Whether that's going to be to take insurance information, just the information or whatever. Um, these also cover any type, okay? So it's at least one of each type of counter. So if you have food service areas, again, it's one of each type. We'll talk a little bit further about that in a minute. Each type of function at the counter also has to be accessible. And where there's more than one counter, we're asking that they be dispersed among all the different types. Slide number 58. Next slide, please. This is just showing that that accessible portion needs to be at least as deep as the part that every other customer gets. So here we're identifying a lowered portion of a counter that's at least the same depth as the higher portion that somebody at a standing position would be using as well. Okay. Moving on to the next slide, slide number 59. So the requirements for that service or sales counter would be that you have either a side or a forward approach. Again, preferably would be a forward, as you see here where this rolls of paper are, where somebody could pull up underneath, especially if you're going to be there for any length of time. It's so important to be able to wheel up there and be able to use it as a surface that's a work surface intended to fill out a form or whatever. A parallel approach really gives you the opportunity to use just the arm on that side closest to the counter. Um, Moving on to the next slide. Public and common use areas is the identifier. We're going to move to the next slide again. Slide number 61 shows an overhead layout of some public and common use areas that I thought I would just identify that could be found in a medical care facility like a medical care suite. And if you had any type of a dressing room or a locker room, even if it's employee only, a locker room, access to at least 5% of each type of locker. And remember that dressing, fitting, and locker rooms also require a dressing or fitting room bench. That bench so that somebody could get on it and maneuver back and forth to change clothing. So if you're providing dressing rooms or locker rooms, at least 5% of the lockers of each type and a dressing, fitting, locker room bench would also be required. Exam rooms and doctor's offices, 100% scoping for public access. If you had toilet rooms, Bobby went through the minimum requirements before, but if they're all single users and they all serve the same area, same population of people, and they're clustered in the same location, that toilet rooms only 50% of single user all in one section need to comply. Now, a men's, a women's, and a single user or family restroom are not permitted to use that exception of 50%. It would be, remember, all the same type. And waiting rooms, public areas would all be accessible. If we could move on to slide 62. Slide 62 is just a graphic of a public common use area. A lot of here is just all loose furniture, but we'd still be looking to make sure that storage facilities or access to any operable parts in public and common use areas, those that are used by anybody there, maybe controls of mechanisms for a fireplace or a TV or things like that. You'd want to make sure your common use spaces, if those operable parts are available and used by the public, visitors, things like that, you'd want to make sure that those operable parts are compliant. Moving on to the next slide. And I just wanted to highlight that if you had dining or work surfaces, maybe you have an area where you provide computers or work surfaces. The requirements in 226 get you access to at least 5% of the surfaces. Applies to both standing and seated spaces, and you disperse those spaces in the facility. So if we're looking for fixed dining surfaces or fixed work surfaces, the requirements in 226 get you 5%. Moving on to the next slide. Slide number 64. I thought I'd throw in this tray slide issue because it seems like every time I'm at the hospital, I'm trying to get some food, right? I'm at the cafeteria or something, and they got a tray slide. And I was like, well, what's the requirements here? And maybe we got to tell people. So it's 28 to 34. You don't have to provide tray slides, but where they are provided, that slide should be between 28 and 34 inches from the finished floor. Okay, next slide, please. I also wanted to briefly just talk about some of the recreation facilities and rehab facilities that you might find in these facilities, and make sure that you do understand there are specific requirements for these type of unique facilities. So if you had a play area, maybe in some waiting room, you'd be looking for the play area requirements you find in chapter 2 and chapter 10. How about an exercise or workout room, whether it's for your staff or the public to go blow some steam off? You would be looking at meeting the minimum requirements for access to at least one of each type of piece of equipment. There's no requirement for the equipment itself to meet any specific types of standards, but there are equipment that do provide upper body exercise cardiovascular, or there are machines that do audio and visual output so that anyone could use, say, the treadmill or things like that, so you have a better access. The ASTM has been working with providing inclusive exercise equipment standards, and that might be a place to look if you're looking to increase the access in your exercise equipment facility. We already kind of talked about locker rooms. Remember, locker rooms would be required, even if they're only for employees, would still be required to be accessible. 5% of those lockers of each type would be required, and that dressing, fitting, or locker room bench. If you had a therapy pool or a swimming pool, or you had saunas or spas, you'd look at the minimum requirements in chapter 10 for those types of facilities. Remember, you'd be looking at a means of entry.
Okay, Bill, we lost you and it's again.
Lost him again.
Okay, Bobby, you want to take over until he comes back?
Sure. And Bill will definitely need, this is definitely his area. Recreation is definitely his area. So we can just kind of go ahead and, in terms of swimming pools and spas, I think he went over that piece already. So we can go ahead and move on to the next slide. I believe we can go to slide number 66. And this is really in terms. Go ahead, Bill. Is Bill back?
I am.
Okay. So,
hey, so
next slide. Yep.
Bobby, are you there?
I'm here.
Go ahead.
All right. So now what we're going to do is we're going to wrap up this webinar and talk a little bit about medical diagnostic equipment. So the U.S. Access Board issues standards for medical diagnostic equipment, or MDE as we call it. So I'm going to give you a brief overview of the medical diagnostic equipment standard. And before I start on this, I just want to go over this brief thing and say that the standards are voluntary. So what we call an enforcement agency, such as like a federal department, like the Department of Justice or Health and Human Services, they would have to adopt these regulations through regulatory actions as a part of their policies to have a mandatory effect. And then likewise, what could happen is a state or another purpose for procurement purposes, they could actually adopt these as well. So these are just a few examples of how the standard be used. So what we've done is we produced a document that is laying the groundwork for future change and also a resource for people to use. And so now the main thing it does is establish a minimum accessible features for the equipment itself. All right, so let's move on to the next slide, slide number 68. Okay, so the Patient Protection and Affordable Care Act, the ACA, it added an amendment to Section 510 of the Rehabilitation Act, which authorized the U.S. Access Board to develop accessibility standards for medical diagnostic equipment. Now, and they did that in consultation with the Food and Drug Administration. So the standards address independent access to and then use of medical diagnostic equipment by people with disabilities to the maximum extent possible. Now, the standards for medical diagnostic equipment apply to equipment that includes examination tables, examination chairs, including chairs used for like eye examinations or procedures. And like if you were going to a dentist, like a dental exam chair procedure, weight scales, mammography equipment, x-ray machines, and then other radiological equipment commonly used for diagnostic purposes by health professionals. Okay, so let's move to the next slide, slide number 69. Now, we're talking about medical diagnostic equipment in physicians' offices and clinics, like emergency rooms or hospitals, and then also dental and optometrist offices as well. Now, accessibility of doctors' offices, clinics, and then other healthcare providers, it's essential in providing medical care to people with disabilities due to barriers. Like individuals that have disabilities, they can be less likely to go seek routine preventative medical care than people without disabilities. So accessibility is not only legally required, it is important medically. Now, to be clear, as I stated before, as issued by the board, the standards are not mandatory on healthcare providers and equipment manufacturers. So the Department of Justice, they may adopt them as mandatory requirements under the Americans with Disability Act law. Other federal agencies may implement them as well under the Rehabilitation Act, which requires access to federally funded programs and services. Okay, so let's move on to the next slide, slide number 70. Okay, so I'm using the term equipment here as opposed to the term medical device, because medical device is really a very broad term. It can include many things, but we are addressing equipment, things such as examination tables and chairs, weight scales and x-ray machines, radiological and mammography equipment. It does not address like personal devices such as like a glucose monitor or a positioning aid, like a wedge. Now, if you had that positioning aid, that positioning piece, that wedge, now you could use that when you transfer onto the exam table, and you could use that. However, that's not what the standard addressed. So to note, the image here on the slide, that the equipment here requires a good amount of physical access with the equipment, and that's when the standards really come up. So they really are most relevant in those kind of furniture-sized pieces of equipment that you have to get on or lay down and position on. And then therefore, we divided the standards in a certain way. Okay, so let's move on to the next slide, slide number 71. Okay, so the standards only address the technical specifications, okay? They are about the features of the equipment that are necessary to ensure a minimum level for the most part of independent access. So it doesn't include scoping, like how many of a particular equipment needs to be accessible, or when this happens, how many accessible equipment would need to be dispersed to the facility. That's not addressed in these standards. That is really up to the adopting agency or the enforcing authority that I talked about earlier. Now, for the most part, the standards are structured on the patient positions, the equipments and supports. So we have four main categories. So we have a category for equipment that is used in the supine or laying on your back position, and then the prone or laying face down on your stomach position, or sideline position, like you would lay on an examination tables, or how you would lay on an MRI machine, and so forth, when you're laying down in some fashion, right? Then our second category is for equipment that is used in a seated position, and that is seated on the equipment and not seated in a wheelchair. So I'll talk about that a little later. So this is seated on the equipment, like you were in a dentist's office and you were seated on a dental chair. That would be an example. Now, you you will note that these first two categories that I'm talking about is for people in wheelchairs. It's about transfers, and that's what most of those requirements are about, transferring onto these surfaces. But we do also address equipment that you will be transferring, but you remain seated in the wheelchair. And that's which is category number three. Now, this would be things like weight scales, or maybe if you have like other equipment that you would pull underneath, like a mammography machine. And then finally, our last category is equipment that you use in a standing position. So, which is a little different than we normally do in our standards. This is geared towards people who do not stand, but have a balance issue, but require supports while standing. So, supports are the primary reason in this category. So, in terms of our four categories, they usually are addressing transfer onto a piece of equipment, how you remain in your wheelchair on a piece of equipment, or if you need to stand on a piece of equipment, and how you would maintain stability. Okay, so let's move on to the next slide, slide number 72. All right, so the ADA requires access to medical care services and the facilities where the services are provided. Now, a good companion piece or a good companion document to the MDE standards is the guidance issued by the Department of Justice on access to medical care for individuals with mobility disabilities. So, this guidance addresses maneuvering situations like in exam rooms, and it's important information about lift use. Also, this technical assistant publication provides guidance for medical care providers on the requirements of the ADA in medical settings with respect to people with mobility disabilities, which can include, for example, like those in like wheelchairs and scooters, walkers and crutches, or no mobility device at all. So you can access this document from the Department of Justice. You can access it at ada.gov. And then you can hit the search criteria. And in the search criteria, you can put in the title of it, which is medical care for individuals with mobility disabilities. And then you'll be able to see the document there. Okay, so let's move on to the next slide, slide number 73, and talk about the medical diagnostic equipment final rule. Okay, so to access the final standards of the medical diagnostic equipment, you can access it in many different ways. But I think one of the easiest ways, you can go directly to our homepage at access, that's access-board.gov. And then you can click on the menu tab from the drop-down menu. You click on the drop-down menu, and then you'll see where it says guidelines and standards. And then from guidelines and standards, then you click on where it says MDE, and then you'll find the final rule. You'll find it there under the MDE tab. Okay. All right. So let's move on to the next slide. And we're going to go over, Bill is going to go over some of the technical guides and closing statements. Bill?
Yeah, thanks so much, Bobby. And thank you so much for all that detail in diagnostic medical equipment. We also just wanted to highlight briefly that at the Access Board's website, we have a series of guides. Some of the recent ones are drinking fountains, bathing rooms, and toilet rooms. We are currently working in chapter 6 and hope to finish chapter 6 real soon. We hope you find these and our animations. And I neglected to say when I was going through signs that we have an animation on signs that goes into greater detail. So please check that if you're looking for additional information on signage. This time we'll move to the next slide. And Lewis?
All right. Thank you very much, Bill and Bobby. Appreciate all of that. All right, everyone, please remember to submit your questions in the chat window, and we'll get to those in a moment. And while you're doing that, I want to remind you that if you were interested in accessible medical equipment, Bobby actually did a webinar for us, and it will be in on adapresentations.org in the archive section of healthcare, and you can look at much more detail about that if you have an interest. And also, I wanted to let everyone know that we are having technical difficulties at adapresentations.org that is preventing the slides from for this session from being put up today, but the archive hopefully will be ready to go for this as usual next week, along with the all the text of this, as well as the recording. All right, let's get to a first question. And while we're doing that, Gabe, can you move on to their addresses? Great, there's the contact information for the access board. So the first question for you all is, where does assistive living facilities fall into place with all of this? Are they fair housing units?
Bobby, you want to address that scoping requirement?
Yeah, so they can be really under what we call like the long-term care. And so that was the, like we said, 50% of the patient sleeping rooms have to be accessible. So but like I always say, it depends on, what services also are being offered in that specific facility. Because sometimes you'll have a facility that has multiple different services that they offer. They may have like a independent living area, and then they may have like a memory care area. So I always tell people, it really depends, what really services or what is being offered in that specific, facility as well.
All right. The next questions refer to the slide where you showed the TTY machine, and there were a couple of comments. One was, now TDD is outdated for deaf, hard of hearing people, but not for people with other form of hearing loss. This needs to be changed. And another person said, will there be an update to add captioned phones and video phones in addition to TTYs? TTY use has dramatically decreased.
I understand that technology has left those devices behind, and there is an understanding, and I think the requirement for TTYs is fewer and fewer, just because facilities are not offering any type of public phone. So they are going by the way. The rulemaking process for the access board to update the 2010 ADA standards is very time consuming and long. Um, I would hope that model building codes, as we discussed earlier, some of the issues with assisted bathing, I would think that this would be the first place that we can get additional technology, communication systems as part of a requirement. I don't know how that's going to be done, but I do know that if it was under the 2010 ADA standards to replace the TTYs, we'd have to open up the whole standard. And at this time, I don't know of that occurring or a timeline to do so. So we're kind of still stuck with the old technology. Um, and hopefully it will be addressed as soon as the access board could continue to do some type of rulemaking to update the 2010 standards, which the last time we updated from 91 to 2010, it was about a 10-year process. And so you can see that if we haven't started yet, it's the access board doing our end, and then the Department of Justice. It's a two-step process, them adopting after we've come up with final guidelines. So it's a ways off, as I'm sorry to say.
All right. The next question had to do with when you were talking about pay stations for parking. And the comment is that pay stations usually only have an audio way to get help, so are not accessible to those who are deaf.
I agree that there's many pay systems that are are doing different types of systems. Hopefully there's an app or some type you can use with your own personal device that will aid in that. But do agree that additional requirements need to be made for both audible and visual communication on those types of devices. Definitely recommended.
All right. The next question, if I have an existing 30-inch leaf double door at an entrance to a medical facility, does adding a low energy powered actuated door connected to standby power allow me to keep the doors?
I'll go, Bobby. Remember, the minimum requirement for doorways would be a 32-inch clear opening. You may be able to achieve that with an offset hinge where it offsets the door clearance further beyond the opening, or the door slab, I should say. That might be a way to get the additional clearance. Typically, a 30-inch active leaf is not definitely addressed by, or an exception for that reduced clear width by adding a device that's either power assisted or automatic. The only exception for adding a power assisted automatic door would be not maneuvering clearance, not the actual width of the door. So it would still most likely need to alter the door itself to be compliant.
All right. Next question. Do you need to identify accessible patient rooms with the ISA symbol? Can you give some examples of informational signs?
I don't know, Bobby, if you
No,
wanted to address this.
no, you don't need to identify the patient room with the ISA symbol. Um, I know we talked a little bit about, the sign in the sign section where the ISA is required. Um, it really depends, but it's not required to have all individual rooms. It wouldn't be required.
Nope, you may have to have it tactile, remember,
You,
or braille would have to be required. If you're identifying a permanent room or space, if this is, a specific room number, you would be looking for a tactile sign,
correct.
and sign to be mounted at the specific height, and a clear space of 18 by 18 underneath that sign near the latch side of the door. But the international symbol of accessibility wouldn't be required on those rooms that are providing clearances or mobility features.
Correct.
All right. The next question, does every exam room require a 5-foot turnaround?
Bobby, you want to talk about that one?
Yes. So yeah, so you want to have, like, talked about that 60-inch diameter circle. You want to have that turning space. And as I said before, one thing that you could do, depending on if you have, you're in a nursing home, you're in some other area, be able to provide more access is always better. Now that turning space, that's a minimum requirement. Okay.
Okay. Next question. If the patient resident is required to pay for a phone in their sleeping room, like a rehabilitation center or a long-term care facility, what is the responsibility of the facility to provide a captioned phone, video phone, or TTY in the person's room? What if the person declines to pay for phone service in their room? And would there have to be a captioned phone, video phone, or TTY for patient resident use?
Wow. I would probably say on this one, it would be better to consult with the Department of Justice on what effective communication is in this specific instance. I've not seen where a captioned phone has been required, um, but it brings up a really good point that effective communication needs to be provided at some level. I would just feel safer that if that was addressed specifically to those procedures to the DOJ. And um, I don't know if we give that number here, but they have a technical assistance hotline that's 1-800-514-0301. And I would suggest that call go there, or
And
question.
If you missed that number, you can certainly call any of the ADA centers at 1-800-949-4232, and
Yes.
we can get you along to them. A couple more questions here. These next two have to do with MRI machines. One is, are there accessible, compliant MRI machines? And the second one is, can you allow a metal wheelchair within a room with an MRI machine, since it's a giant magnet?
Now, so we don't, what I talked about before with an MDE, we don't really address that piece. But what we do in terms of being able to have access to that room, the standards for medical diagnostic equipment, it just, like I said before, it really just looks at the equipment, and it doesn't really, address those other other factors that relate to it as well. But I also want, before we go on to something else, I want to just make note that if you have any MDE questions, medical diagnostic equipment questions, you can also email me directly on those questions too, and I can make sure I respond back to you as well, okay?
It does address, though, the platform size in which you would transfer and handholds and things like that, and the height of the table in which you would have to get on for an imaging machine based on how you would do it. I personally have brought a wheelchair into an MR machine room and haven't had any problem with the magnetic issue. I don't know about power, but typically once you're positioned on the table, they remove the chair or anything else from that area. And so I've not seen where there's been any adverse effect or heard of any that has resulted in that being in that vicinity or room.
All right, well, there are a lot of questions piled up, and I'm so sorry that we are not going to be able to have time to answer all of those. We apologize if you didn't get your question asked, but you can contact the access board there at that number and that email on the screen right now, or you can contact your regional ADA center at 1-800-949-4232. And if we can't answer it, we'll certainly get you onto the access board as well. You all will receive an email with a link to an online session evaluation. Please complete that evaluation for today's program, as we value your input. We want to thank our speakers, Bill and Bobby, today for sharing their time and knowledge with us. That was an excellent presentation, and we're getting a lot of those excellent messages in the chat. A reminder that today's session was recorded. It will be available for viewing next week at adapresentations.org in the archive section of healthcare. And our next webinar on February 25th, Lisa Iazzoni will present her research on healthcare disparities for people with disabilities and the potential role of physician bias. We hope you can join us. Watch your email 2 weeks ahead for the announcement of the opening of that registration. All right, thank you again, Bill and Bobby. Thank you all for coming today, and we thank you for attending, and we will see you next time. Have a good rest of your day. Bye-bye.
I apologize for the connection problems I had. I was doing everything I could to get back in as fast as I could. Thank you,
No
Lewis.
problem. Thanks, Lewis.
Bye, Bobby.
All right, take care.
Thank you, interpreters. Sorry we went so fast. Thank you again.
Thank you so much.